Okay, let's dive in. We are tackling a really major update today. The KDI Go 2024 Clinical Practice Guideline for Chronic Kidney Disease. Huge topic.
It really is. And this isn't just, minor changes. It's a full-on comprehensive review bringing together all the latest evidence. It's quite the document.
It is dense. So our mission here is to kind of wrestle with it, pull out the absolute must-know insights, and make them, well, actionable for you. Whether you're new to CPC or you've been following it for years, this is your fast track to understanding the state of play in 2024.
Okay, so where do we start? Maybe just the basics. CKD, chronic kidney disease. It's about kidney structure or function problems that hang around for at least 3 months.
Right. And the guideline uses this system, the CGA system, to really classify it.
CGA cause, GFR category, and albuminuria category. So GFR, glomerular filtration rate, basically, how well a kidneys filter blood.
Yeah, and the categories run from G1, which is pretty much normal function, like over 90 milliminim, 1.73 millimons, all the way down through G2, G3A, G3B, G4.
Down to G5, which is under 15. That's kidney failure territory.
And the A in CGA, albuminuria, that's protein, specifically albumin, in the urine, a sign of kidney damage.
Exactly. 3 categories there. A1 is normal, or just mildly up, less than 30 milligrams. A2 is moderately increased, 30 to 299. And A3 is, well, severely increased, 300 or more.
And the power here, like you see in that figure 13 grid in the guideline, is putting GFR and albuminuria together. It gives you this color-coded risk level.
Right. Green is low risk, but as GFR drops and albuminuria climbs, you shift into yellow, orange, red. Higher risk for kidney failure, heart problems, you name it. It's a really foundational tool for prognosis.
Okay, so that's how we stage it. How do we actually measure this stuff?
Well, the guideline digs into the key tests, estimating GFR, usually called eGFR from blood tests, and measuring albuminuria, typically using that urine albumin to creatinine ratio, or ACR.
And accuracy is a huge theme, isn't it? They really stress using standardized labs, even listing things that can mess up the creatinine measurement.
Absolutely.
Yeah.
And here's a big shift they recommend. If possible, use an eGFR calculated from both creatinine and another marker called cystatin C. It gives a more accurate picture.
Oh, interesting. Using both markers.
Yeah, eGFR-CR, as they call it. And they reinforce using the 2021 CKD EPI equation, the one that importantly removed race from the calculation.
And for the urine test, the ACR, or sometimes PCR, the protein ratio, that's better than just measuring albumin concentration.
Right, because it corrects for how dilute or concentrated the urine might be on that particular day. Gives you a more stable measure of the actual albumin excretion.
Makes sense. What about those quick tests, point-of-care testing?
POCT, yeah. Super useful, especially maybe in remote settings or places without easy lab access. But, and this is a big but, the guideline says they must be validated. Like, one practice point mentions they should catch significant albuminuria, that ACR over 30, at least 85% of the time. Reliability is key.
Gotcha. So quick isn't always enough. It has to be accurate, too.
Exactly. And because, lab results can vary day to day, or even just biologically, they strongly recommend confirming any abnormal result before you slap on the CKD diagnosis. Remember, it's chronic, needs to be there for 3 months. You got to rule out acute kidney injury, AKI or AKD, acute kidney disease.
Right. Confirmation is key. And beyond the numbers, understanding the cause is vital too, isn't it?
Totally fundamental. They talk about using imaging. Sometimes a kidney biopsy is needed for a definitive diagnosis. And increasingly, genetic testing is playing a role. They list specific genes like APO1 or the PKD genes for polycystic kidney disease. It's becoming clear that genetics might be involved more often than we used to think.
Okay, so we've got the diagnosis, the stage, maybe an idea of the cause. Now what?
Yeah.
Monitoring, right, keeping track of things.
Yeah, tracking progression and risk. The guideline gives pretty clear advice on how often to monitor.
So how often is that?
Minimum, check GFR and albuminuria once a year. But if you're in those higher risk categories, the yellow, orange, red zones on that grid, you need more frequent checks to catch changes earlier.
And what counts as a significant change? Something you really need to pay attention to.
This is super helpful guidance. They say a drop in eGFR of more than 20% from your last measurement warrants a closer look. It's likely more than just random variation.
Okay, a 20% drop, that's a concrete number.
Right. And similarly, for albuminuria, if it doubles like 100% increase, that's also considered significant and should probably be confirmed with another test. These are triggers for action.
And they're big on using risk prediction tools too, aren't they? Like the KFRE.
Yes. The kidney failure risk equation. It takes things like your age, sex, GFR, ACR, and sometimes the cause of CKD, and calculates your percentage risk of needing dialysis or a transplant within, say, 2 or 5 years.
And that's not just academic, right? It has real-world implications.
Absolutely. It helps guide conversations about the future. For instance, the guidelines suggest using thresholds, like if the KFRE predicts a greater than 40% risk of needing kidney replacement therapy, or KRT, within 2 years that might trigger discussions about dialysis options or planning for vascular access, even if the GFR hasn't hit that specific low number yet.
Wow, okay, so it helps personalize the planning.
Exactly. And don't forget cardiovascular risk. CKD massively increases heart risk. The guideline stresses that standard heart risk calculators might underestimate risk in people with CKD, so using CKD-specific tools is better.
Right, got to factor in the kidneys for heart health too. Okay, so we've diagnosed, staged, monitored risk. What's the first line of defense in management? Is it straight to meds?
Actually, no. The guideline really emphasizes lifestyle as the foundation. You see it visually in their figures. It starts there,
Okay, so what does that involve?
the core stuff. Encouraging regular physical activity that's right for the person, aiming for a healthy weight, and crucially, stopping smoking. No tobacco.
And that applies to kids too, right? I saw a note about that.
Yeah, they specifically mention encouraging kids with CKD to meet the standard physical activity goals. It's important for everyone.
And diet. That's always a big one in CKD.
Huge. The recommendation is for healthy, diverse eating patterns. More plant-based foods, fruits, veggies, whole grains, legumes, and less ultra-processed stuff.
But the specifics can get tricky with sodium, potassium, phosphorus.
Exactly, which is why they strongly recommend working with a renal dietitian.
Mm.
You really need that personalized advice to navigate diets safely and effectively in CKD.
Makes sense. What about protein? That's often confusing.
It is nuanced. Generally, moderation is key.
Yeah.
But they're careful not to recommend very low-protein diets for people who are metabolically unstable. And two really important points. For kids, they say don't restrict protein because they need it for growth.
Right. That's crucial for kids.
And for frail older adults, they might actually need higher protein and calorie intake to fight frailty. So it's not a one-size-fits-all restriction.
That's a really important clarification. And the plant-based angle seems strong.
Yeah, they reference studies suggesting higher plant-based protein intake might be linked to slower GFR decline. And there's this interesting detail, figure 33, about potassium. It suggests that potassium from many whole plant foods might be less readily absorbed than potassium from, say, processed foods or meat additives, which could be relevant for managing potassium levels.
Huh, that's fascinating about potassium bioavailability. Okay, and of course managing blood pressure and blood sugar are still vital pillars too.
Absolutely. Often with specific meds like RAS inhibitors for BP and tight glycemic control for diabetes, referencing other specific KDIGO guidelines for those details.
Okay, lifestyle's covered. Let's move into the medications. This is a huge part of CKD management for many people.
Definitely. And the guideline provides a lot of detail. So key classes, RAS inhibitors, that's your ACE inhibitors or ARBs, often recommended even without high blood pressure because they protect the kidneys.
Right, the kidney protective effect.
And then the SGLT2 inhibitors. These have been, well, kind of revolutionary. Huge benefits shown in slowing CKD progression, reducing heart failure risk. They're recommended broadly now for many people with CKD.
And you can use them even when kidney function is quite low.
Yeah, the guidance suggests they can often be continued even down to an eGFR below 20, basically until someone starts kidney replacement therapy.
Wow, okay. What about managing cardiovascular risk with meds?
Aggressively. Statins are recommended for most adults with CKD to lower cholesterol. The benefits seem consistent across different GFR levels. And then antiplatelet therapy, like aspirin, is considered, but it's always a balance between preventing clots and the risk of bleeding, tailored to the individual.
Makes sense. What if someone has AFib, atrial fibrillation, and CKD?
The general principles for managing AFib and preventing stroke are the same. For blood thinners, they discuss the newer direct oral anticoagulants, the NOACs, versus warfarin. Trials including CKD patients suggest NOACs generally lower stroke risk similarly or better, and importantly, seem to cause fewer serious bleeds, especially brain bleeds, compared to warfarin in this population.
Okay, so NOAC is often preferred, but still individualized.
Exactly. And they give practical advice on things like how long to hold NOACs before a procedure, depending on the specific drug and the person's kidney function.
Given all these potential meds, and the fact that kidneys clear drugs differently, Managing the whole medication list must be critical.
Oh, absolutely critical. They call it medication management and drug stewardship.
Yeah.
Polypharmacy taking lots of pills is common, and CKD changes how drugs are handled. So regular, thorough medication reviews are essential, especially during transitions, like going into or out of the hospital.
Right, making sure nothing falls through the cracks.
Yeah, and adjusting dosages based on current kidney function is non-negotiable. The guideline has tables listing common drugs that need dose adjustments. And it also flags drugs known to be potentially harmful to the kidneys, nephrotoxic drugs.
Like what?
Well, the usual suspects like NSAIs, ibuprofen, naproxen, certain antibiotics, PPIs, the stomach acid drugs, even contrast dye used for some scans. They have specific warnings about gadolinium contrast for MRIs in people with very low GFR.
And I saw something surprising in there about herbal remedies.
Yes, that really stood out. Figure 45 lists examples from around the world, things like starfruit, willow bark, certain traditional Chinese herbs that have been linked to kidney toxicity. It's a stark reminder that natural doesn't automatically mean safe, especially when your kidneys are vulnerable.
Wow, good to know. What about sick day rules? I've heard about that.
Ah, yes, very important practical advice. It means temporarily stopping certain medications when you get acutely ill, like with vomiting, diarrhea, or a fever, because dehydration can make these drugs riskier.
Which drugs are those typically?
They often use the acronym SAD-MANS. SGLT2 inhibitors, ACE inhibitors, ARBs, diuretics, metformin, and NSAIDs. Stopping those temporarily during illness can prevent acute kidney injury.
A sad man's. Okay, that's helpful.
But here's the crucial follow-up. You need a clear plan for when and how to restart those medications once you're better. Stopping is only half the story. Restarting is just as important to get back the long-term benefits. Misusing these rules can cause harm either way.
Right, need the full plan.
Yeah.
And patient education about all these meds seems key.
Absolutely. And they highlight the value of involving clinical pharmacists and using electronic health records with decision support to help manage complex medication regimens safely.
Okay, beyond slowing progression and managing risks like heart disease and meds, CKD often brings specific symptoms and complications. How does the guideline address those?
Yeah, quality of life is a big focus. It covers managing common complications like potassium problems, acidosis, anemia, bone issues, malnutrition. The list goes on.
Let's take potassium. High potassium, hyperkalemia seems common.
It is, especially with lower GFR and certain meds like those RAS inhibitors. The guideline has an algorithm for how to manage acute high potassium and lists drugs that increase risk. And again, diet plays a role, referencing back to that figure 33 on potassium sources.
What about gout?
So for gout and high uric acid, the recommendation is clear. Treat with uric acid-lowering drugs if the person has symptomatic gout painful flares, especially if uric acid is very high or CKD is advanced.
Okay, treat the symptoms.
But, and this is a key point, they recommend against using these drugs just to lower uric acid if someone doesn't have gout symptoms, purely in the hope of slowing CKD. The evidence for that benefit just isn't there.
Interesting distinction. Don't treat the number if there are no symptoms.
Exactly. They also mentioned a specific genetic marker, HLA-B5801, found more often in some Asian populations, which increases risk for severe skin reactions to allopurinol, a common gout drug. Something to be aware of.
Good point. And other symptoms, like itching.
Yeah, they emphasize managing common, bothersome symptoms to improve daily life. Things like pruritus, itching, restless leg syndrome, and adapting pain management strategies, because many standard pain meds aren't safe for CKD.
And malnutrition.
Screening for malnutrition is recommended, particularly in more advanced CKD, older adults, and children. If identified, then nutritional therapy with expert guidance is needed. So, managing all this complexity. It really sounds like it takes a village, so to speak. Teamwork seems essential.
Absolutely. The guideline heavily emphasizes the importance of referral to specialist kidney care services for many patients.
And there are specific criteria for when that referral should happen.
Yes, figure 48 lays it out. It's based on specific GFR or ACR levels, or how fast function is declining, or if complications like high blood pressure or anemia are hard to manage, or if there's suspicion of a genetic cause.
And getting referred early makes a difference.
Big time. The guideline cites evidence linking earlier referral to better outcomes, better survival, more time to prepare for potential dialysis or transplant, better management of complications overall. It contrasts this with factors often linked to late referral, like older age, certain racial or ethnic groups, lower socioeconomic status. Unfortunately, disparities exist.
That's sobering. And once someone is in specialist care, what does optimal care look like?
Patient-centered, multidisciplinary, team-based care. That's the gold standard. It's not just the nephrologist, it's nurses, dietitians, pharmacists, social workers, all collaborating with the patient. Figure 50 shows this model visually.
Makes sense. And the patient's role.
Absolutely central. Patient and family education is stressed as crucial for self-management and shared decision-making. They talk about effective education strategies and also the growing role of telehealth, using web resources, apps, video calls to support patients.
What about younger patients? Transitioning from pediatric to adult care could be tough.
Yeah, that's a really high-risk period, especially for those under 25. The guideline gives specific advice. Start preparing early in adolescence, have written summaries, ensure a stable transfer time, and encourage adult providers to recognize the unique needs of these young adults, maybe even having joint visits before the final handoff.
That sounds critical. And then planning for the possibility of kidney replacement therapy, KRT dialysis or transplant.
Right. Planning should begin based not just on GFR falling below a certain level, like 15 or 20, but also if that KFRE risk score is high, like over 40% in 2 years, it prompts the conversation early.
And starting dialysis itself, is it just based on the GFR number?
No, and this is important. The decision to actually initiate dialysis should be based on the patient's symptoms and clinical signs of kidney failure, not solely on the lab value. They mentioned the IDEAL trial, which found no survival advantage to starting dialysis early, based only on GFR if the person felt relatively well.
Okay, symptom-driven initiation. And what if someone chooses not to pursue dialysis or transplant? That's explicitly addressed. Comprehensive conservative care is presented as a fully supported pathway. It involves planned, holistic care focused on managing symptoms, advanced care planning, psychosocial support, basically, maximizing quality of life without dialysis. It's an active choice, not just doing nothing.
Wow. Okay. This guideline is incredibly comprehensive. It really covers everything from, the nitty-gritty of lab tests and drug doses all the way up to team structures and end-of-life planning. It shows just how much the field of CKD care has advanced.
It absolutely does. And they call it a dynamic, evolving resource themselves, which I think is key.
Yeah, and that brings us to a really interesting thought for you, the listener. If these guidelines are constantly changing, constantly evolving based on new science, what does that mean for how we approach medical information, how we engage with our own health?
It suggests that learning isn't a one-time thing. It's about staying curious, staying updated, understanding that recommendations might shift over time as we learn more.
Exactly. How can knowing that guidelines like this exist and that they change empower you? Maybe it helps you ask better questions or feel more confident discussing options with your doctor or just understand the why behind certain recommendations. It's definitely something to reflect on.